All right. Thank you so much, everyone, for having me today. I'm going to figure out how to share screen without, here we go. All right. Hopefully everyone can see that. All right. So I'm going to be talking about the complete blood count for a general pediatrician. Like I said, what's kind of great is that I'm still really learning about this topic as well. So it's great that we'll be able to learn together. I have no disclosures aside from the fact that I'm still learning as well. What kind of recently prompted this talk was that I'm here on Kauai, on the island of Kauai, and what's so special about being a community pediatrician here in Kauai is that I not only get to practice in clinic, but I get to do a little bit of inpatient, outpatient, ERs, and nursery, and go to deliveries. I think that's the reason why I really enjoyed wanted to work on a neighbor island because of the vast variety that I get to see. And what prompted this talk was this recent case that I had in which I had a newborn. And this is what a complete blood cell count looks like with the white count, red count. We'll go through some of these terms in just a bit. But when I looked at it, it's been a while since I saw a newborn that had some abnormal counts. Cause then, for us, for me as a pediatrician, I'm like looking at it and I'm like, well, Epic isn't really flagging this as red, so that means it's probably okay. Why are these values so high, the hemoglobin and the hematocrit? I only look at this value for anemia, and I only use this value for when I do something with hereditary spherocytosis. And I just realized that, this is an important topic that we get taught throughout medical school and any other healthcare careers, but it's always nice to be able to do a quick refresher on it. And I'll be able to share with you later that this CBC actually turned out to be completely fine, despite all the reds on the screen. But just as a quick introduction about the CBC, so the American Academy of Pediatrics recommends screening for anemia between 9 to 12 months of age, meaning every single person, every single baby between that time period will get a blood draw to screen for anemia. And they also recommend additional screening between ages 1 to 5 with patients at risk, which includes patients who's had previous anemia lab results or patients who drink excessive amount of cow's milk, which can cause an increased risk for anemia as well. Something that I feel like I should have known, but I didn't until this particular talk, was that there's racial and sex differences within the complete blood count, that males tend to have higher hemoglobin values than females, and blood count averages are typically based on the white population, which is kind of similar to what in the past, the glomerular filtration rate, which was how our kidneys function. They used to differentiate it between our white population and our non-white population. But now, we've been straying away from putting in any racial differences. So on the complete blood count, there are no racial distinguishings on the actual lab counts, but I think it's something important for us to keep in mind. So for us today, I wanted to kind of break our talk up into three categories of the CBC, which is the red blood cells, the white blood cells, and the platelets, and kind of go through each of them on how to interpret a CBC, what looked like in the recent case on a step-by-step basis. So first and foremost, we'll talk about the red blood cells. So just as an overview, red blood cells are responsible for gas exchange and oxygen delivery to the tissues. The average lifespan is about 120 days. So the red blood cells, what's interesting on the CBC, has most of its indices or more descriptive factors that can talk about the erythrocytes or the red blood cells, such as the hemoglobin, the hematocrit, the mean corpuscular volume, the distributive width, the red blood cell count, etc. I won't go through each of these individually, but I wanted to talk about kind of a step-by-step on how we should look at the red blood cell interpretation. So the first step is taking a look at the hemoglobin value. So we look, if the hemoglobin value is 2 standard deviations above the mean, the CBC count should be repeated. And if it is 2 standard deviations below the mean, then that would be constituted as anemia. In this article that I'll have in my reference has a really nice chart in terms of an average hemoglobin, hematocrit, and all the rest of the RBC indices. I just didn't include it onto this slide per age in a pediatric population. So as you can see over here on the left, for 1 to 3 day olds, you can see that the hemoglobin and the hematocrit, as they tend to go side by each other, are highest at birth, and they kind of come down nicely until they're in the low to mid-teens for adolescent and into adulthood. So just to recap, we take a look at this, we find out how old our patient is, take a look at the mean, and we look at the the 2 standard deviation window that the articles give us. And if it is 2 standard deviations above the mean, then the CBC can be repeated. And if it's below, then we consider that to be anemia. I think this is important for someone like maybe if we're not at a children's hospital, just because, for example, when I was in residency in Kapiolani, a lot of the EPIC values for pediatric patients would be already incorporated into the pediatric chart. But for example, in a community pediatrics, for someone like me practicing outside here in Kauai, all of the CBC counts are typically based on adult values. So it may be considered abnormal in an adult population, but normal in a pediatric population. So having an indices table like this is very helpful.
Can I interrupt with a couple of questions that popped
Sure.
up in the chat? Regarding your case, Dr. Ware is asking whether the cord was stripped prior to clamping, and presumably how that might affect your the numbers that you get. And then Dr. Begay is asking about the results. Are they red flagged based on the table that you're showing? Which I assume the answer is probably no, that rather the labs are determining like what they're red flagging and not red flagging.
Correct. So the red flags on this page is based on what the lab has determined as normal and abnormal. So this was a fresh newborn. And this is straight from EPIC. So in our lab, they had deemed that it's a normal hemoglobin should be between 16.3 and 19.3. But when we go back to this table, you can see that, we have a 2 standard deviation ranging from the baby's not even 1 day old, but I don't have anything lower than that, between 14.5 and 22.5. And then for this particular case, the cord was not stripped prior to clamping. This is actually a precipitous delivery at home. So that's a little bit of a sidetrack, but but it prompted us to get a little bit more of a workup in a newborn that we usually wouldn't get otherwise. All right. Good questions, though. Okay, I'm going to go to, so once we've determined that the hemoglobin is either, 2 standard deviations above or 2 standard deviations below the mean, we can go to, what's nice about this particular article that just came out in July is that it gives you a flowchart algorithm to attack each of the values independently. And I'll kind of go through these 2 branches independently. So I'm going to first go through the low hemoglobin count, which would be for the anemia. So once we kind of determine, I'm coming down this arm of the diagram here, that we have an anemia, our second step would be to obtain a reticulocyte count. If we see that it is elevated, we can see that it is, the anemia could be based on destruction or consumptive processes. And then the third part, or maybe concurrently more than 2 and 3, is to look at the mean corpuscular volume. To look at the volume, and then to see if the red blood cell if the red blood cell is small, big, or normal size. So microcytotic, macrocytotic, or normocytic. And then if it is considered small, our etiologies include a dietary evaluation to consider iron deficiency or family history, such as thalassemia. If it is big, we can also think about some other dietary evaluations, such as folate or vitamin B12 deficiency, or any other medication exposures. Some common ones that we use, there's an extensive list of medications that can cause macrocytosis, but common ones that we use in pediatrics include seizure medicines such as phenobarbital, antibiotics, which includes trimethoprim, and then some methotrexate, which is used in some autoimmune and cancer conditions as well. What's the most challenging is if they are normocytic, which has the vast amount of differential diagnoses. We would like to look at the reticulocyte count and the peripheral blood smear, and also to perform a direct antiglobin test. A positive test of that would indicate autoimmune hemolytic anemia, and a negative test would indicate the microangiopathic hemolytic anemia or an inherited RBC disorder. So that's kind of our branch down our anemia chart. And I wanted to go on to the other side of this diagram and look at polycythemia. Oh, and sorry, one more important note is that for normocytic anemia, a careful HMP is important, as reticulocytosis of greater than 3% can occur after 2 to 3 days. So perhaps if we are getting a history and we don't see an elevated reticulocyte initially, it might be important for us to repeat a reticulocyte in 2 to 3 days after initial onset. So for high hemoglobin or polycythemia, if it is greater than 2 standard deviations, we will repeat the CBC to make sure it stays elevated. If it normalizes, then we suspect, dehydration or hemoconcentration at that point. If it is persistently elevated, then we look for risk factors for other polycythemia. So some factors that reduce the number of oxygen reaching tissues, which would result in the high hemoglobin count. These would be some of the factors such as congenital heart disease, so children would have a greater number of hemoglobin to help deliver the appropriate amount of oxygen to the tissues, elevated altitude for the same reason, smoking, obstructive sleep apnea, and genetic conditions such as polycythemia vera. Kind of going quickly through these because I do want to make sure we have some time for questions, is the next section is for white blood cell count. This is also quite a bit of a section because there are components within the white blood cell count that is quite elevated, that is quite extensive. So as you know, the white blood cell count is divided into 2 major groups, such as granulocytes and agranulocytes. Whenever we have an abnormal white count without any preceding thought of the reason why we would have an abnormal count, it is important to repeat to see if it normalizes, particularly if patients have no other symptoms or signs. If still is normal, it's important that we can consider repeating in 2 to 4 weeks, as the most common acquired neutropenia or lymphopenia will resolve in a few weeks. And again, this is for cases in which the patient doesn't have any other conditions or thoughts of the reason why that would cause an abnormal white blood cell count. So that was something that I learned as well, that if it's abnormal and they don't have any symptoms, just go ahead and repeating it in 2 to 4 weeks was something important that I learned. So similar to the red blood cell count, I wanted to kind of make a step-by-step in terms of how do we interpret the white blood cell count. So first is to look at the total white blood cell count, and there is a chart in this paper similar to the red blood cell count of age-specific counts. And if the total count is within 2 standard deviations, we can look at the differential cell count and calculate absolute cell counts should be calculated to identify cell abnormalities. Oh, so I see the question I see a question in the chart. If there is an illness, would still repeat in 2 to 4 weeks? No, I don't think so. Because then we would see that it is still, we would attribute the white blood cell count being abnormal to the illness, and I don't think there would be a need to repeat it in 2 to 4 weeks. This is that if you're, for example, you're getting a routine CBC and you weren't expecting anything, but you see that the white blood cell count is abnormal, you can repeat it in 2 to 4 weeks to see if it is if it normalizes on its own. The white count also has a place in that, we tend to trend it, as in if we see like a big infection, and if we see it coming down, we get comforted knowing that, the infection is getting well controlled under antibiotics. So I think in some cases we do tend to repeat the CBC for trending purposes. But if there's an obvious illness, I don't think we routinely repeat again in 2 to 4 weeks. Hope that answers that question. So going back to our white blood cell count interpretation, looking at the total count, looking at the differential cell counts, this kind of takes us down to this particular diagram, assessing the white blood cell count. And similar to the red blood cell count diagram, we go down the lower than 4,000, where the white blood cell count is low, high, or normal. And so I'm going to go down the low white blood cell count, which is less than 2 standard deviations. The main thing that this article was saying was that check if there is an overall deficiency of all cell count types versus if it's just a specific cell type. For example, if the white cell count, the red blood cell count, the platelets are all low, consider repeating, or is it just isolated on its own? And for the opposite end, with the elevated white blood cell count greater than 2 standard deviations, so if there are presence of immature or abnormal white blood cells, it's important for us to get a peripheral blood smear. And if there is a simultaneous cytopenia, such as anemia or thrombocytopenia, also important for us to get a peripheral blood smear. And then lastly, for asymptomatic patients with a confirmed infection, repeat in 2 to 4 weeks. If the cytopenia persists, evaluation continues based on that predominant cell type. Something that I didn't mention in the red blood cell count, but I wanted to mention here, is the importance of, even if you have a normal white blood cell count type, even if you have a normal hemoglobin type, if there is a component or an indices of the red blood cell or the white blood cell that is abnormal, it is still important for us to investigate it. So I didn't get to touch on that too much, particularly for the basis of this talk and time. So now I wanted to go through about the white blood cell differentials to talk about each of the different cell types, because they each have a different diagram as well. So the neutrophils, which is our cells that help fight infections. Some things that are important is that the number of neutrophils at birth are higher owing to bone age surge secondary to stress of delivery. So neutropenia is less than, and an absolute neutrophil count of 1,000 until 2 years of age. And severe neutropenia is ANC less than 500. What was kind of cool was that, neutropenia, again, we just talked about this right over here. And the neutropenia can be broken down into 2 big categories, such as destruction or consumption, or decreased production. Wait, sorry, I didn't mean to click that. So if a patient with an acute infection or neutropenia, for example, a CBC should be referred within 2 to 4 weeks. There's also drug effects over here that can cause neutropenia. So something that I learned was that if a patient is on a long-term medication, such as antipsychotics, anti-seizures, or other immunosuppressive medication, a CBC should be repeated in 2 to 4 weeks. And if it's still neutropenic, then consider a change in therapy. I actually didn't know that. So that's something interesting that I had learned. If a newborn is found with neutropenia with additional cytopenia, we should look for other etiologies for possible leukemia, such as lymphadenopathy, hepatosplenomegaly, and getting a peripheral blood smear and a lactate dehydrogenase level. And this was a good reminder for me that leukemia may present with either high or low white counts. So an otherwise healthy kid who is younger than 2 years with an ANC of 1500, repeat at age 2 and no other management is necessary. And then for those who are wondering, not enough vitamins such as vitamin B12, folate, and copper can also cause neutropenia. I always had thought that it was related to just the red cell count, but it can also affect the white blood cell count as well. So that was neutrophils, and I wanted to talk a little bit about lymphocytes. So lymphocytes includes the T, B, and the natural killer cells. So children have a predominant, sorry about that. Children have a predominant number of lymphocytes during the first 2 years of life. Lymphocytes can be reactive in the setting of an infection, but should resolve. They were previously called atypical, but the language is now turning to become reactive. So just as an FYI, patients with lymphoid malignancy will often have additional cytopenias. So for lymphocytes, this was a similar diagram looking at low lymphocytes versus high lymphocytes. There's a diagram of what we can do to take a look at how to address it. So for lymphopenia, assess if the patient's age and if it's well or sick. If they don't look well, we can consider an immunodeficiency syndrome. And we can see if there is a history of infections. On the other end, lymphocytosis, important to review a peripheral blood smear and evaluate for infectious etiology. And if there are other cytopenias, we can evaluate for malignancy. And if there are reactive lymphocytes on the peripheral blood smear, it's most likely related to an infection. Some of it was called the atypical lymphocytes previously. And then the last category was the eosinophils. So eosinophils are commonly seen in allergic conditions, which is the most common cause in the United States. And the second most common cause is infections or parasites, followed by malignancy and hypereosinophilia. So this diagram kind of talks about how we can kind of break these down, making sure what the calculations are for eosinophilia and what the common culprits of eosinophils are. I know that was a lot for the red cells and the white cells. Just want to take a quick breather. And before we head into our last section of platelets, and then we'll do some questions and we can talk about any other cases afterwards. So our last section is platelets, which are these cute things on the slides here. They play a key role in hemostasis. The lifespan of each platelet is 7 to 10 days. What is the most interesting thing that I learned is that platelet numbers and normal values do not vary with age, whereas the red blood cell count and the white blood cell count do throughout. So an elevated platelet count can be caused by acute or chronic inflammation in addition to anemia. So kids who are anemic, particularly severe anemia, can also trigger the bone marrow to create more platelets. So it can cause elevated platelet counts as well. Thrombocytopenia, the other end of the spectrum, where we have low platelet count, there is a risk of bleeding. It is considered a severe bleeding list when we have less than what we say 20. If it is low, it's important to obtain a mean platelet volume to determine destructive or inherited etiology. I actually personally have never done this, but this was something interesting for me to learn as well. That's why this diagram is a little bit more extensive in terms of assessing a platelet count. If it is low, this article taught me that it's important for us to get a mean platelet volume. And this is probably more, the time where we would refer to a specialist, but this would kind of tell us what kind of genetic condition or other primary causes of low platelet count can occur. High platelet counts is the primary thrombocytosis is quite rare in children, but secondary causes such as iron deficiency is quite common. So kind of to recap, my key points from this talk today were, when in doubt, repeat the CBC. And if there is no reason for us to believe that the CBC is abnormal, repeat the CBC in 2 to 4 weeks was important. And then number 3, looking at the RBC indices, even if the hemoglobin may be normal, which is the same for the differential count for the white blood cell count. And I think the peripheral blood smear this paper was saying was quite underutilized, so not being afraid to utilize the peripheral blood smear based on the diagrams and looking for possible etiologies as well. Thank you guys. And I do want to pass it over to Summer to do some MOC questions, and then afterwards I'll go ahead and take some questions. Thank you. I'm going to stop share real quick. All right. So we have 4 questions. The first one is, true or false, in a patient with anemia, platelet count may be high owing to anemia, true or false? Number 2 is, when there is abnormal white blood cell count with no other symptoms, when should the CBC be repeated? Number 3, children at birth tend to have higher or lower lymphocytes during the first 2 years of birth in comparison to adults. And lastly, and this would be a case, you obtain a routine hemoglobin and hematocrit on a 9-month-old male and note to have low hemoglobin levels for his age. Which of the following lab values should be looked at next? I think I put an extra should in there. Which of the following lab values should be looked at next? Great. I see some answers coming in. And I think if there's any questions that that anyone has along the way, after you're done with the poll, go ahead and start dropping them into the chat.
Maybe you could discuss the answers to the questions as soon as folks are done with the poll. And then I see at least one question that's in the chat. Can you see the chat easily, or do you want me to relay the questions to you?
I could see the chat.
Okay, great.
All right. We'll give a few more minutes for the poll questions, if that's okay.
Yeah, I'm gonna give it a few. We're about 60% done, so I'd like to get it at least to 75. And we've got plenty of time. So. Yeah, I'll go ahead and end the poll. And then Dr. Noel, if you could review the questions and answers for us. These are good. They're kind of split, split answers. Oh, I think you're muted. Sorry.
There we go. I wanted to make sure that I didn't talk too much, so I muted myself. But so the first question, so in a patient with anemia, platelet counts may also be high. Just for the owing to the anemia by itself? Well, the answer is true. So there's actually two theories on this. The first is that, the anemia is thought to trigger megakaryocytosis, which would increase the production of platelets. Likewise, in anemia, the bone marrow precursor, there's a common precursor between red blood cell counts and platelets. So when there is anemia, the bone marrow is triggered to make more of these cells, saying, okay, let's make more red blood cells. But at the same time, it also makes more platelets. So the answer for number one is true. Okay, so number two, so when there is an abnormal white blood cell count with no other symptoms, when should the CBC blood tests be repeated? So the answer is 2 to 4 weeks. So B, or the second one. The most common acquired neutropenia or lymphopenia will resolve within a matter of a few weeks. And number three, children at birth tend to have higher or lower lymphocytes during the first 2 years in comparison to adults. So this is higher. And the complete reason is that there is a expansion of the thymus, which is the organ or part of the body that is opposed to making this, which cause a decrease from the expansion of it the expansion of the thymus and the naive cells cause decrease in lymphocytes from birth until adulthood. And then lastly, so we have a 9-month-old, you get a routine H&H hemoglobin and hematocrits recommended by the American Academy of Pediatrics, and note to have low hemoglobin levels for his age. Which of the following should we look at next? So according to the diagram, it's going to be the reticulocyte and MCV, which is the first choice. So the reticulocyte, if elevated, we can consider a destructive and consumptive process. And the MCV, the mean volume, can help determine for possible etiologies of it. For example, that's a recap on if there's microcytosis, then there could be some dietary deficiency or family history. And if it is big macrocytosis, we can consider for dietary deficiencies as well. And if it is normal cytic, normal size, there's a whole bunch of other differentials as well. Any questions on the questions itself? And then I'll kind of tackle some of these other questions as well. Give it a minute. All right, thank you guys. Okay, so the first question is, are you able to discuss the transition from fetal hemoglobin and adult hemoglobin and how this might affect hemoglobin values and reticulocyte values in the first year of life? I actually tried to look at this. So when babies are first born, we have fetal hemoglobin or hemoglobin F, and they switch to hemoglobin A within which is considered the adult hemoglobin. The hemoglobin F is found to bind to oxygen a little bit more rapidly than hemoglobin A. The full transition takes about 2 years. In terms of the count itself, I don't know how the fetal hemoglobin and adult hemoglobin itself would cause the transition to be different. I just know that the hemoglobin values in infancy is higher than adulthood, particularly because there is a higher metabolic need. And I actually tried to look for that when I was looking this talk, but I couldn't find something on it. I hope that answers that question. And then, so Dr. Begay says, so sometimes percents are abnormal, but absolute values are normal and vice versa. What do you believe? So from my understanding, it was looking at this study, it was particularly counting on the absolute numbers. The absolute cell counts was the one that you actually tend to favor. So this is the article that I kind of based my complete talk on is called the Complete Blood Count, a practical tool for a pediatrician. It just came out in last month in Pediatrics in Review, and it was written by 2 hemonc physicians. And when I look at sorry, I need to go to the white count. So once we have an abnormal white count, and we look at the type of white count, it says to go ahead and just calculate the absolute counts of each of them. So I would say it is the absolute count that we depend on more. And then any insight about increased monocytes, what do they mean, what to do with them? Yeah, it's kind of interesting because monocytes can be affected by a few things. So I learned through, this talk that monocytes is a precursor. It is one of the first cells that come when there is new cells being made. What to do with them? This article didn't particularly talk about it, but I just remember in residency that if there are monocytes, what to do with them is see if it is caused by inflammation, because even diet can affect monocyte conditions, such as, foods that cause inflammation, such as like red meats, fried foods. So seeing that, I feel like when we see monocytes, we see it as like, okay, our body is fighting the infection, or our body is in a constant inflammatory state. And if the child has any reason to be ill, to repeat it after the inflammatory process or infection process is gone, was what I would do. But this article didn't particularly talk about it in detail that I had looked at. And hemoglobin F binds oxygen more efficient, I think. Is this right? Yes. So hemoglobin F does bind oxygen more efficiently than hemoglobin A. All right, good questions.
Those were really great questions. And I invite you guys all, we still have a few more minutes with Erika. So if you have any more questions, feel free to throw them in the chat. One thing that I was doing while we were talking was looking up that article in Peds in Review, and I realized not everybody has access to as much library materials as we do. So for anybody who would like, you can send your email to either put it in the chat and Summer will grab it, or send it to me or Summer, and then we can send you that article. Are there any other questions right now? Otherwise, I have a couple of my own. Okay, yeah, Renata, just put your email in the chat or send it to Summer, and then we can make sure that happens. So one thing I was wondering is about eosinophils. You mentioned that they can be elevated, and I couldn't read it. Actually, it was really small. I think there was like a sort of mild, moderate, and severe or something cut off. I have found, in the hospital, we fairly frequently repeat things quickly because of whatever reason, because the patients are sick. And sometimes you can go from like an eosinophil count that is like noticeable of like, say 9 or 12, and then the next day it's 3. And so I'm curious, in an outpatient setting where you're typically not repeating something every 12 or 24 hours, what's your cutoff for like going, hey, I really need to pay attention to this with eosinophils. Maybe my kid needs an O&P, or if they don't have obvious asthma or other sort of atopic symptoms. What is your cutoff and why?
Yeah, it's kind of interesting because over here in Kauai, we have very I didn't know, I'm still in Hawaii, but Kauai is a little bit different. So it's interesting because, for example, one of the most interesting cases that I have is that we have a lot more chickens here on Kauai than Oahu. And I didn't know that because of that, we have a lot of Campylobacter infections from chickens, which before I kind of associated Campylobacter infections with dogs only, but chickens have it. And over here, in addition, like for example, we have a little bit more of eosinophilic esophagitis, more than I've seen in the Oahu when I was in residency on Oahu. I think when I did my GI rotation, I think we've only diagnosed like one or two of them, but over here I've seen it more and more commonly. And it just seems like it's something a little bit more common here. And I asked everybody and the GI doctors, and they don't quite know why. So when I see an eosinophilia, my brain actually starts to go that way, just because we've seen it a little bit more commonly here. And I think our cutoff here is that I have asked my partners, and they say that like at 10, they'll repeat it again in a couple weeks. And if it's still elevated, then they'll do more investigative work, is what I've learned. But I'm not I don't know like a hard science to it either.
Maybe this is a dumb question, but what's the connection between Campylobacter and eosinophilic esophagitis?
Oh, no, there is no connections. I was just giving an example of like, it's interesting that I've learned that, Kauai brings different things. And again, I don't know why eosinophilic esophagitis is something that's not, I don't want to use the word common, but similarly to Campylobacter, eosinophilic esophagitis is something that I've seen more here.
Okay, that makes so much more sense, because I thought I missed something and I was confused. I'm also curious, and you might not be surprised to get this question from me about the race-based values for like hematological norms, and I think specifically for ferritin and for hemoglobin. So I did actually look up some stuff about that too while we were talking, and I'm curious, and I have an article I could share too that is like a commentary in Lancet Hematology about why it should be eliminated, based on race being a social construct and not necessarily being or not being any kind of like representation of ancestry, or even something that's static, right? Because it changes over generations, and is something that's subjective in some cases. So I'm curious what you were finding, and how you think about navigating that, like in the context of like health equity and trying to sort of understand that we are always doing categorization in medicine, and at the same time that using race-based values can lead to health inequities, because of like decreased, like the GFR example, right? So there was a higher threshold for Black patients to be diagnosed with kidney disease in each stage of CKD or end-stage renal disease, because of the fact that there was this race coefficient, which basically resulted in fewer Black patients qualifying for a transplant than white patients with comparable disease.
Mm-hmm. Yeah, I agree. I think and that's why I think, for the GFR, I think what I've been seeing is that what's kind of nice is that the CBC has always been, in terms of racial equity, there hasn't ever been any racial differences. And I think the GFR is the only one that's ever been, I think from my understanding, is the only one that's kind of been categorized, differently. And we're kind of moving away from that. But I think how we make sure that it continues like that, for me personally, is that I didn't actually even know, and particularly for the CBC, that there were any racial differences, even though I remember reading, in passing that, maybe some particular racial groups have higher hemoglobin concentrations, etc. But I feel like I actually didn't know that until this talk, that there was racial differences. So I feel like it's being taught now that, there aren't, it's not being taught as that there are racial differences within or, that's not the main focus of learning the CBC. So I feel like we're moving in that right direction of there should be no racial differences, and we don't put them into categories. But it's just something to know, but not commit to memory, to take care of patients. I don't know if that
Or
answers.
maybe to be attentive to not like using a certain threshold to eliminate like a further workup, right? So that's what this commentary is kind of making the point that we
Right.
shouldn't say, oh, this is normal because the patient is Black and therefore we don't do a further workup, but rather if we think that something is on the low end, then we should be doing an appropriate workup regardless of race, while obviously considering ancestry is different from sort of like just sort of putting a race box around somebody.
Yeah, for sure. Absolutely.
There's quite a bit more commentary too in the chat, talking about eosinophilia. Yeah, definitely parasitic infestation is very common, and it can put your eosinophils high. I don't know what's the highest you've ever seen, Penny or Erika or anybody else, but I feel like I've definitely seen it probably in the 20s at least.
Yeah, I was gonna say the 20s is probably what I've seen.
Yeah, Penny, is that about the same for you in the 20s when you see eosinophilia in the patients in American Samoa? She said, yeah, okay. Yeah, so I think probably somewhere around 10 or 12 is your cutoff for thinking this might be something as opposed to just it's random. That's a good way to think of it, because I often wonder when I see numbers kind of between like 8 and 12, do I need to like do a big workup? Do I do a little workup? Do I make sure someone repeats it on the outpatient side? You know, and sometimes those things don't happen and stuff like that. So it can be tricky to know what to do. Okay.
I think for us, yeah, we just get a good history, and if it is anything concerning, because we have a lot of freshwater exposure here, and if there is, then maybe that'll kind of dictate. If not, we'll repeat it in a couple of weeks.
Yeah. Oh yeah, especially amongst children who run barefoot in the village. Yeah, for sure. I think we have less of that here, probably because, you know, we have like better access to resources in general, but we certainly do see kids come in with parasites from time to time, just not as commonly. Renata was making some points about dietary contribution to eosinophilic esophagitis, which I actually don't know about that. So I don't know if anyone else can comment. Dr. Nagamori is still on the call, so I don't know if you want to weigh in at all on that one.
I think it's the ones that were mentioned, like I only know of wheat, milk, egg. And then
I don't know if they contribute like in terms of causing it or if they exacerbate it if you are like already diagnosed.
That's true. I actually don't know that minutia, to be honest.
Yeah, me neither. And it sounds like Dr. Nagamori is not unmuting, so that's fine. Any other last questions, folks? We still have a couple of minutes, but we're always happy to end a couple minutes early. I think we got a huge bang for our buck from this talk. And I definitely, several people have been asking for the article. So I'll download a copy and send it to Summer, and then she can forward it to everyone who's interested.
Awesome. Yeah, thank you. I know it was a lot of just go information. So
but it was so straightforward. That's really, really useful. Yeah. Because it sometimes you know, you really want to know like, what do I do and where do I go? And I think what's nice about this article, actually, we can probably are we still able to post it on the ECHO website, Summer, as a resource? Because I have the PDF now, so it wouldn't be behind a paywall.
You can email it to me. I'll also post it on our ECHO resource and directly email the ones who chatted.
Okay. All right, that sounds great. And I'll just give you folks a quick reminder that we have another one of our recent graduates giving next ECHO session, which is on the 16th. So Dr. Jayman Singh, who is now a cardiology fellow, recent graduate from here, came back actually to visit when our most recent class was graduating in order to be able to celebrate with them and to make sure that he got to put some lays around necks. So it was really special. He's
Yeah.
going to be talking about the family history of sudden cardiac death, which is a really important topic. And I think that I certainly have questions about at what point do you work something up versus saying it might have been related to, age factors or things like that. And we have this sort of rough cutoff of 50, but there's so many other factors that play into decisions about what should be worked up and what shouldn't, or how much to work up or what workup to do. So I think we'll all learn a lot from that, and we're really looking forward to it. And for now, I'm going to go ahead and close, and there's lots of thank yous in the chat. I'm going to add mine to say, Erika, thank you so much for coming back to visit and giving us such a clear and excellent talk. I think it'll be really useful to everyone on the call. And we will look forward to inviting you back in a year or two, not too often, because I know it was a lot of work.
Thank you guys so much. Appreciate it.
Yeah, thank you. Bye, everybody. See
Bye,
you.
everyone. Thank you, Dr. Noel.